So please join me in welcoming Dr. Cynthia.
Mosbrucker. As Tina said, I'm from Washington, and it's an honor to be here with you. I met Kathy probably, 15 years ago or so, and she kind of blew my mind. She sent me this patient, and she said, I think she has adhesions here and here, and I think she has endo, and I think she has this and this and this. And I saw her, and I talked to the patient, and I'm like, when did this start? And she's like, well, I was hiking, and I slipped on a rock, and I kind of stepped hard. And I'm like, it's your hip. Go get your hip fixed, and then, come back to me if it doesn't work. She comes back, like, 3 months later, did a bunch of hip PT, had it injected, didn't make a difference at all. So she begs me. She's like, will you please operate on me and make sure that what Kathy thinks is going on is or isn't going on? And I'm like, okay, fine. And I really kind of did it just to shut her up. And lo and behold, everything to the T that Kathy thought was going on. And I'm like, holy smokes, this woman really knows what she's doing. And so that began the love relationship between me and Kathy, although I haven't seen her in years. But I have been informally trained by a lot of PTs. I owe a lot that's in this lecture to Carrie Hall, who took care of me after I had my hip scope for impingement and a labral tear, and nothing else worked. And so I have a PT in my office now, Terry Sullivan, who's fabulous. And so how many of you, I'm just curious, how many of you have shared patients with me over the years? Raise your hand. Holy smokes. Well, talk to me afterwards. I'd love to put a face to the name. I'm horrible with names. But I appreciate what you guys do, because you guys spend so much time with people and you can really educate them. And lately, we've been getting more referrals from PTs than we do from anybody else. And so I think that a lot of gynecologists are like, they don't understand endo. The general surgeons don't understand endo. The family practice docs don't understand endo. And so I think that PTs, and especially pelvic floor PTs, are much more open to information on the reality of what makes endo and how we treat it than our regular MDs. And so with that, I will quit wasting time and proceed. I have no disclosures other than I'm a little bit passionate. Which may be hard to tell, but after a while, you can see. So Tina fortunately went through most of this stuff. I did grow up in Fircrest. Went to Wilson High School in Tacoma, and then I went and spent 8 years in Chicago. But when it came time to come home, I was happy to come home. When I was in Hawaii, I kind of felt like there was this little angel sitting on my shoulder, tapping me, saying, "There's something more you're supposed to be doing." And that's when I met Dr. Redwine, and talking to him and emailing with him and communicating. It's like, this is everything I ever wanted to do, because when I was in med school, I had a hard time deciding, should I do urology, should I do general surgery, or should I do GYN, because I love them all. And now I get to do all of that. Plus a little bit of hip ortho and a little bit of PT, mostly thinking along those lines rather than actually doing it. But so I've had my own practice for it'll be almost 9 years, and I have 2 fellows. Actually, one finished her fellowship, but she still needs a little bit of help. Dr. Newville from time to time, and then Dr. Yagi, Jen Yagi, who helped me with a couple of videos that are in this presentation. So thanks to those guys. And so let's begin. This is a non-photoshopped real photo of endo in a patient, and I love it. Just the evil eyes. So, the definition of endometriosis is the presence of endometrial glands and stroma outside the uterine cavity. The most common locations are in the posterior pelvis. So the uterosacral ligaments, cul-de-sac, the ovarian fossa, which is also called the pelvic sidewalls, are far and away the most common place for endo to live. It can also live over the bladder, it can live on the abdominal walls, it can live rarely on the diaphragm, in the lung, and then impinge on the sciatic nerve. Intestinal endo affects, some studies show like 11-12% in the general population. In referral practices like mine and like Dr. Redwine's, it was 30% of our patients have intestinal endo. And that includes, so the vast majority are on the rectosigmoid, but the appendix can also cause a lot of nausea. Small bowel endo can cause nausea and bowel obstructions. In fact, the most common site of bowel obstructions in women with endo is the terminal ileum. So, classic symptoms are sharp stabbing and burning pain, which may be central, it may be lateral. Typically, it starts out right around the time of the period, and then as time goes on, it gets more and more and more, eats up more of the month. A lot of women will have a flare at ovulation, and then it gets better, and then it ramps up prior to menses. Some people, it'll just be, 3 weeks out of the month. Almost every day they have pain, some better, some worse. And typically, over time, that's how it progresses. So, making a diagnosis of endometriosis is really not that challenging, which is why it just kind of blows me away why gynecologists take 9 years on average to diagnose somebody with endo. It's disgusting. And like Tina said, a lot of our patients, I'd say probably 75-80% of our patients have had at least one surgery. And when I was with Dr. Redwine, this one woman had 13 pelvic surgeries for endometriosis and didn't get any better. This other gal came in and she had pain right here. And first they took out her right ovary, then they took out her uterus, then they took out her left ovary. You know what it was? It was endometriosis in her appendix stuck to her genitofemoral nerve that gave her pain right here. She wouldn't have needed to lose any of her parts, but she did. So, if you understand the history, oftentimes these women will also, say, when I was 12, I started my period, and 2 months later, I started missing school. They put me on birth control when I was 14, 15 to control my periods. And sometimes birth control kind of keeps it at bay, and sometimes it doesn't. Dyspareunia is kind of classic. A lot of our patients can tell between their endo pain and their adenomyosis pain, their uterine pain. A lot of this stuff I don't need to tell you guys, you understand, but this was originally from a lecture to the doctors, and so I have to tell them how to do a pelvic exam, because otherwise they'd stick a big giant speculum in and then 2 fingers and kind of go all over the place. And you can't tell what's from the pelvic floor and what's from the uterosacrals and what's from the cul-de-sac. If you're sticking 2 fingers in and you're stretching out the introitus and they have pain in the introitus, if they have vulvodynia and you even touch the perineum, you're, forget about figuring out what hurts anywhere else. You're toast. So, ultrasound is really helpful, even though technically you can't really see superficial endometriosis with an ultrasound, but we can see endometriomas, we can see adhesions, we can see how the uterus and the ovaries and the sidewalls and the rectum, we can see all those things move. And when they don't move and the ovaries are stuck to the sidewall or the ovaries are stuck to the uterus or they've got a mass in the rectum from endometriosis, then we can tell that they have probably more advanced disease. But what I generally tell my patients is when they have a history that's classic for endometriosis and they're tender on the either sacral ligaments in the cul-de-sac, we find endometriosis in surgery probably upwards of 95%, probably 97, 98% of the time. We will find endo. CT is pretty much useless. MRI can see what it can see, but it only gets into the interpretation if the radiologists understand what they're looking at. And so UW actually has the best radiologist to look at endo, and maybe some in Kirkland, but most radiologists, they don't know what they're looking at. I had a patient who had 4 surgeries in Seattle and came to see me with this MRI that said there's a little bit of tethering between the vagina and the rectum, and turns out she had an ovarian remnant. She had a 5-centimeter nodule of endometriosis, which I could see on my ultrasound when I first put it in there. And she was miserable. And we operated on her and got all this stuff out. And all these people in Seattle that called themselves endo specialists had been in there before and either didn't see it or didn't want to see it. So you guys probably know this if you're working on my patients and you do a lot of pelvic pain, is that endometriosis is stage 1 through 4. There are some newer staging systems, but all of them basically kind of talk about superficial disease versus deep disease. The classic ASRM system was designed for infertility. Stage 1 is superficial disease with no adhesion. Stage 2 is deeper disease, which deeply infiltrating endometriosis is defined as more than 5 millimeters in invasion below the peritoneal surface. Stage 3 is endometrioma. Stage 4 is obliterated cul-de-sac or intestinal involvement. And the thing that baffles gynecologists is that stage 4 patients oftentimes have very little pain, whereas we'll see teenagers with 2 or 3 spots of disease, and they're like, oh, I'm in 10 out of 10 pain, and it's horrible, and I can't do anything. And in reality, pain and disease run in parallel. And what that means is that the type of pain and the location of the pain will be defined by the disease, what it looks like, where it is. But the amount of pain is determined by the patient's own pain sensing system. So their own pain threshold, how sensitized they are, and it's like I said, you guys understand pain processing much better than physicians do. So some of these slides were from an old pain processing lecture. So anyways, I like to think of endo rather than stage 1 through 4 is peritoneal disease, deep disease. Deep disease will penetrate into some of the somatic nerve fibers, and so there's more of a correlation between where somebody feels pain and where the disease is in deeper disease, whereas peritoneal disease typically runs through the visceral pain system, and so it's harder to localize it. One of the guys at NIH that was one of our attendings actually did a study that showed women with endo, half the time their pain is on the opposite side of where most of their disease is. But that should make sense to you guys, because for me, half the time, one side hurts worse, but the other side is so much more in spasm. And I think you guys find that quite often, don't you? When you treat people with whatever, rotational disorders of their spine and pelvic obliquities and all that kind of stuff. So, and then endometriomas are a marker for intestinal disease. So anytime I see somebody who's got an endometrioma, I always kind of play the Spanish Inquisition about their bowel habits and pain, because I want to know if they have bowel disease before we go to the OR, because we need to figure out what do we need to do to fix it. We'll talk about that later. Treatment, hormonal suppression with either birth control and progestins. The literature says 80% efficacy. Maybe I'm not seeing those 80% of patients, but I'm seeing the 20% that it doesn't work. Marina IUD, sometimes it helps, sometimes it makes things worse, especially in the setting of adenomyosis, so I don't push it. If somebody wants one, we can try it. If they need birth control for birth control, okay, fine, but I don't make my patients do it. GnRH agonists like Lupron and Orlissa, there was a Cochrane database study that showed no value over progestin as far as pain relief, and the side effects are way worse and sometimes permanent. So I will never ever give anybody Lupron. The only or Orlissa or any of those things. The only time that there's any value, I think, to the GnRH agonist is prior to a egg transfer for IVF in women with adenomyosis. There's been some data that shows that the transfer success rates are better when the uterus is suppressed. Aromatase inhibitors are, they don't stop ovulation, they just stop peripheral conversion to estrogen, so they're not really very helpful. So what do we do? Well, there's surgical options. What we do is excision of endometriosis, which is removing all visible disease no matter where it is. Ablation is what most, probably 99% of gynecologists do, which is what I was trained to do 30 years ago, which is go in and go zap, zap, zap over the lesions that are not on the colon, not over the ureter, not in really important places, and so you can't burn half of the lesions that you see. Moreover, you're only getting the top 1 to 2 millimeters, and if there's deep disease, that's going 5 millimeters, sometimes even thicker than that. So it's really not very helpful. So here's some pictures. This is about as close as we get to a normal pelvis. Here's the uterus, which is very round. It's not supposed to be that round. That's an indicator of adenomyosis, but we'll get there later. Fallopian tubes, this one is more normal. This one's a little goofy looking, but the ovaries are normal. The cul-de-sac, this is the rectum down here. All the yellow stuff is fat. Don't tell the patient. What I look at, though, is the uterosacral ligaments. I look at this arch. And if it looks like the Peace Arch in St. Louis or Blaine or wherever there's arches, and it's symmetrical and beautiful, then great, there's probably no endo there. But if it's not, and there's more tension on this side, you can see that band of tissue kind of pulling, that's an indicator that there's endo in there somewhere. So this is what I would call stage 2 endo. So you can see these little things. Redwine used to call those tapioca spots. And what always happens with endo is that there's this halo of fibrosis around the lesion. And that's the body's reaction to it. So sometimes you'll read an op note that says there was endometriosis everywhere. And generally, that's not the case. Generally, what that means is that the woman had an endometrioma that leaked, and the hemosiderin, which is the breakdown product of iron, and the blood products that are in the endometrioma, those things get everywhere. But there's not a halo around them, and so that's how you can tell what is real endo versus what's just fluid from a leaky endometrioma. So if your patients bring you in pictures, you can look at them and say, hey, I listen to Mosbrucker, and this isn't endo. So this is what it looks like. This is that same patient after excision. So we've kind of recreated more of a normal arch on her uterosacrals. We've taken out the sidewall. Here's 2 perfectly normal looking fallopian tubes. This is stage 3. This is a big endometrioma. Here's a nodule in the rectum. Here's big, giant kissing endometriomas. These were like 7 centimeters. This patient actually got pregnant about a year after her surgery. So I was happy about that. This is another picture of stage 4 disease. This is a big dilated fallopian tube, so hydrosalpinx. This is endo in the rectum, and so the white is the bowel wall, the yellow is the either the mesentery or pararectal fat on the epicloaca. And you can tell, because this is rounded, it means that there's a nodule inside the bowel wall. Whereas if it comes up and it's more of a sharp corner from the uterus to the bowel wall, it's just stuck. It's just adherent. There's not disease within the bowel wall. But this one clearly had a big old rectal nodule. This is a really ugly picture, and I probably should find a better one to put in here. But this was after a stage 4 resection. And then this is like 2 years after. This is a patient that we did excision of endometriosis, and she was 44, had adenomyosis. I'm like, you should have your uterus out. She's like, no, I want to keep it. And so 2 years later, she comes in, my periods are horrible, I'm bleeding like a stuck pig, and take my uterus out, please. And this is what we saw. This is the border line of where all this stuff was excised. This is native peritoneum, this is reperitonealized. And the argument that most gynecologists give for not doing excision is, oh, it's going to cause adhesions. She's dying of her adhesions. There aren't any. It's a joke. So yes, sometimes patients, especially with stage 4, when we do bowel resections, when we do endometriomas, some patients get adhesions, but it's probably in the order of 5 to 10% that get significant, really dense, concrete adhesions that are going to cause pain. The little filmy adhesions, things can still move, and it's the ability of the ovary to move when it ovulates. When the cyst forms in the ovary and it's stuck down, then it's going to cause pain because it's pulling on the sidewall. So sometimes patients that have had adhesions in the past, when we operate on them, I want them to get into visceral mode as soon as they can, maybe 2-3 weeks post-op, so that you guys can work on helping the ovaries not stick to things, helping the colon not stick to the back of the uterus. You guys make me look good, so I need you. This is just another gal with an evil uterus and big bulky disease of the uterus sacral. Fortunately, her tube and ovary look pretty good. So adenomyosis is endometriosis of the muscle layer of the uterus. It's only been probably 15 years or so that the radiologists figured out that they can see adenomyosis on ultrasound. And because of that, there's not a lot of data for adenomyosis and fertility. But what we know of symptoms is that adenomyosis causes this crampy central pain. A lot of times it'll just fill the whole pelvis. One patient came in and said, feels like I've got a hot fireplace log sitting in my pelvis. And I think that's about the most apt description of adenomyosis that I've ever heard. Kind of the sine qua non that I look for is that they have crampy pain at the end of an orgasm, because at the very end of an orgasm, the uterus contracts, and for most of my patients, that contraction is not pleasurable and is painful. Some have it for 5-10 minutes, some have it for 2 or 3 days. Adenomyosis can also cause this crampy pain after exercise, and so my athletes have a problem too. So again, hormonal suppression, women without an IUD, IUDs I think are usually not very helpful. We do presacral neurectomies, which is where we cut the hypogastric nerve, the sensory nerve that brings the pain impulses from the uterus to the spinal cord. In the literature, 75% of the time, that is helpful to dramatically decrease the uterine crampy pain that our patients feel. It doesn't completely get rid of it. I tell my patients it makes you like a friend, so you can take some ibuprofen and carry on. You're probably not going to feel like going out and training for a marathon or hiking Mount Rainier. But, if you can go to work, go to school, come home, and still do what you need to do, you don't go great. But, you can function, then hallelujah. You're not laying in bed in the fetal position with the heating pad on your belly. Pre-sacral neurectomies don't do anything for the bleeding, and adenomyosis, the tendency is that as somebody gets older, they have heavier periods and worse bleeding, and the PSN won't really help that. So I've had more than a few patients come in and they've had a PSN, 3, 4, 6 years ago, and they're like, either I had my last kid, or I had a kid, or I decided I don't want to have a kid, and now I'm bleeding like crazy. Will you take my uterus out? Okay, fine. So I kind of think of a PSN as like a temporizing measure. It's not the be-all, end-all, but it helps and it buys them some time to have their families, and probably half of them wind up with a hysterectomy, although that's not in the studies, that's just my personal observation. So what causes endometriosis? Everybody is taught in medical school that Sampson's theory or retrograde menstruation is what causes endometriosis. That menstrual blood refluxes out of the fallopian tubes and goes into the pelvis and causes endometriosis. Well, let's talk about that. Reflux menstruation happens in just about everybody, but only 10% of women have endo. It should result in a random distribution of lesions throughout the pelvis and increasing number of locations as somebody gets older. And Redwine did studies that refute that does not happen, that lesions are very much confined to the areas that we talked about before, the uterosacrals, the cul-de-sac, the pelvic sidewalls. When endo is on the bowel, it is always on the anti-mesenteric surface. So the mesentery comes up from behind, and then the bowel wall is round, and endo is almost always, like 99% of the time, on the anti-mesenteric surface. Sampson's theory should result in endometriosis being genetically identical to endometrium, and it is not. David used to say, show me a photomicrograph of implantation and I'll believe it is Sampson's theory. Nobody can, because it doesn't exist. So it also can't explain the locations of endo outside the abdominal pelvic cavity, such as the brain, the lung, the prostate, and they are very, very rare, especially the brain and the prostate. So they're like, worthy of case reports in the literature. But what Sampson's theory means is that you can never cure endometriosis unless you do a hysterectomy. And we know that that's not the case. So what is the theory that I think is correct? And it is the theory of peritoneal metaplasia. It can also be called murillariosis. They're basically the same kind of thing. So in 1972, this pathologist named Laughlin wrote a paper on the secondary Mullerian system. And essentially the premise is that the peritoneal tissue has the ability to morph into tissue that looks like the Mullerian system. So the uterus, the fallopian tubes, the upper vagina, the cervix, so we see endosalpingiosis, which is a cousin of endometriosis, that looks like the lining of the fallopian tube. So it has these little ciliated cells on it, these little sweeper cells. It still causes pain, and it still causes what we really don't know about fertility implications of endosalpingiosis, but we see it. Endocervicosis looks like a little glob of mucusy stuff from like cervical mucus that's trapped in a little ball. I can't say the next one. Adenomyosis peritonealis disseminata. I've seen 2 cases of that in my life, one when I was a resident and one about 8 years ago. And basically it's fibroids coming from everywhere. They're not stuck in the uterus, they're in the rod ligament, they're on the bowel mesentery, they're on the omentum, they're everywhere. And then primary peritoneal carcinoma, where the ovaries aren't classically part of the Mullerian system because they're gonads, but it's where women who've had their ovaries out develop what looks like ovarian cancer. So anyways, moving on, the mechanism for which this peritoneal metaplasia takes place is that the genes responsible for the formation of these Mullerian structures are left on when they're supposed to be shut off. So in baby girl fetuses, reproductive differentiation takes place somewhere between 6 and 10 weeks of fetal development. And these genes are supposed to be turned on so that the Wolffian structures don't form, the male genitalia don't form, and the female genitalia forms. And then the genes are supposed to turn themselves off. But in women with endo, these genes persist. And then when girls go through menarche and their ovaries wake up and start making estrogen, then that estrogen is like water and fertilizer for the seeds of endometriosis. And that's kind of how I explain it to my patients, is that these seeds are genetically programmed where they are, which is why endo lives in the uterosacrals and the sidewalls and the posterior pelvis predominantly, and why it doesn't go everywhere. So this is the genetic reason for the formation of endometriosis. And then this guy, Signorilli in Italy, wrote a couple of papers on these autopsy studies that he did on little baby girl fetuses that had been aborted or miscarried or stillborn. And he looked at 36 female fetuses anywhere between 14 weeks and term, and then he stained the posterior pelvis for CA125 and estrogen receptors to see where the endometriosis is. And he found, guess what, 11% of them had endometrial glands and stroma outside the uterine cavity. So endometriosis happens in utero. Endometriosis happens in fetuses. So, and then finally, this is the last whip that I'll use to beat a dead horse. So this is an ovary with endometriomas, with an endometrioma. And this stuff here, this is a close-up, looks like if you took a sample of the endometrium, it looks just like this. So this is endometriosis developing out of the normal epithelium of an ovary. And so essentially what they're saying with this study is that we see the initial transformation from normal going into endometriosis. And it's not like you copied and pasted this and just plastered it right on there, which is what you would see if it was endometrium coming from the uterus through the fallopian tubes and glomming onto the ovary. So all these things taken together tell me that I don't have to have faith in peritoneal metaplasia. I can understand it as a scientific truth. And so all these things that we've been talking about, the ability to morph into Mullerian types, the static nature of the disease, all this kind of stuff, tells me that peritoneal metaplasia is true. And what it really means is that we can excise endometriosis and get rid of it. And 56% of the time it doesn't come back. So, ablation, going back to ablation, it just burns 1 to 2 millimeters. You can't get to the deep stuff. It doesn't work over important structures. Excision, we can remove everything no matter where it is. There are not a lot of studies on ablation to this day. There are probably single digits. And the ones that did study it show, this one was 2 groups, one excision, one ablation. They followed them for six months, but all had very superficial disease, and the outcomes were kind of equivalent. This other study, 6-year follow-up of laser ablation in stage 1 and 2, 74% chance of pain recurrence at an average of 20 months. None of these studies included stage 4 endo, so even if you think that ablation might work for really superficial stuff, it doesn't do anything for the deep disease. This is one of, I think, a really interesting article. They published the first version of it in 2010 and then a kind of a follow-up in like 4 or 5 years later. And what they did was they randomized patients with endo to excision and ablation, and then the people that followed them up didn't know what they had. So that's why it's blinded, double-blinded. And if all you did was read the abstract, it says there's no statistical significant difference in pain at 12 months. But then you go and actually read the study and you realize that the abstract is a whole bunch of horse pucky. Yes, I grew up on a farm. They powered their study for 75 patients, and they lost 21 and 25 patients. So they only had 49 in the ablation group, 54 in the excision group. Not only that, the groups weren't similar. The excision group had 53% with deep disease and only 22 in the ablation group. 4 in the excision group had stage 4 disease, none in the ablation group. And then they had whoever, including the residents, perform the surgeries. But then when you actually go in and look at their data, and these are reduction in visual analog scores, so bigger is better. And defecation pain with defecation, the excision group 1.8 better, 0.7 in the ablation group. Nausea 1.7 compared to 0.6. Bloating 2.4 compared to 1.5. Dyspareunia 3.1 compared to 1.8. I bet you money that if they had powered their study appropriately, that all of these in red would be significant. So, on to other studies. These are 4 studies from the 80s, 90s, and 2000, early 2000s. Sounds like a radio station. This one is the one that I'm most familiar about because David Redline did it out of his database. So he kept a database of every patient that he ever operated on, and then he could mine his database and query it and write papers. That's how he wrote like 40 papers while he was raising 2 boys, working full time, building a house, and having a practice. The guy never slept. Essentially, what this study showed was in all of his patients, and these are all cohort studies, these are all basically, these are our patients, we operated on it, and this is how we did it, which is how most surgical studies are. The very few surgical studies are randomized, controlled, double-blinded, whatever, because it's too hard to do that. So roughly half of these patients had another surgery in the 7 years that he followed them. So he'd send them questionnaires every year to ask them how they were doing. And in the patients who had subsequent surgery, only 43% had evidence of endometriosis on pathology, which means 57% did not have endometriosis anywhere from a year to 7 years after the original surgery. The other half, roughly, didn't have any surgery and they didn't have any pain. And so when you combine the 57% surgical cure rate with the patients who didn't have any pain, the upshot is a 19% chance of persistence or recurrence of disease, which is similar amongst all of these different studies. Wheeler's was in Texas. They did open laparotomy. This one was in Europe somewhere. This one was in Australia. It doesn't matter where in the world you are, good excision is good excision. More recent studies of outcomes, my favorite guy is Horace Roman from Rouen, France. And Dr. Roman does a lot of bowel disease, and he does these crazy discoid excision for these huge nodules that are really low in the vagina. He does crazy disease. And he has written with his group, has written a lot of papers on recurrence rates, on fertility rates, especially after operating on patients with stage 3 and 4 disease. So you can see the vast majority of his patients had fairly severe disease. They did 14% of their patients over 5 years had repeat surgeries, and 10% had recurrence of endometriosis. And the majority, well, I guess not the majority, but a plurality of the surgeries, the repeat surgeries, were hysterectomies for adenomyosis, which is not a failure of the excision, it's just another bad thing going on. Pregnancy after surgery and then hysterectomy were protective. Hysterectomy at the first surgery were protective and reduced the odds of requiring a second surgery. This is a meta-analysis. I should be shutting this down here because I get your guys' time. This is a meta-analysis of 4 studies. So they looked at actually like 150 studies and decided that only 4 really met their criteria. Looking at fertility after excision of deeply infiltrating endometriosis, so stage 3 and 4 patients, and they compared primary excision before fertility treatments or 2 failed IVF attempts and then surgery. And what they found is a 1.8 times higher conception rate, a 2.2 times higher live birth rate. And if you do the math between those two, the miscarriage rate went down substantially. And so this is the paper that I quote to my patients when they come to see me with infertility, and they're like, should we do IVF? Should we do endosurgery? And I'm like, well, this is what I think based on these 4 studies. Then this is another paper that is it's a paper on endometriomas and fertility. Let's just go there. Ovarian endometriomas, as you know, are cysts of deeply infiltrating endometriosis in the ovary that can substantially negatively affect fertility. And so people have been trying to figure out what's the best way to operate on them and still preserve fertility. And so cystectomy is what we do. We open up the ovary, we peel the cyst wall out, and then we close the ovary back up again. Drainage and ablation is something that, when it's done with bipolar cautery, it's very bad. But Dr. Roman uses this thing called a plasma jet, which is plasma energy, and it doesn't penetrate as deeply. And so they basically burn the lining of the cyst wall, but they don't peel it out of the ovary. And what that does is it helps to preserve a few more follicles compared to cystectomies. But cystectomies are variable depending on who does them. And so if you read the literature on ovarian cystectomy and fertility and AMH levels, which AMH is anti-mullerian hormone, which is a marker of fertility, it's all over the map because they don't control for the skill of the surgeon doing the surgery. So in this paper, they basically agreed, and it was a meta-analysis review of a gazillion different studies, is that cystectomy has the lowest risk of recurrence of the endometrioma and associated pain. The AMH is probably the most common marker of ovarian reserve, which is the ability of the ovary to ovulate in the future. Antral follicle count is something that's done by ultrasound on, I think it's day 3 of the cycle, and they're basically seeing how many primordial follicles are there trying to grow up and become the follicle that ovulates. I always think they're like little kids at a baseball game. Pick me, I want to be the dominant follicle. I want to grow up and ovulate. So ovarian cystectomy does, and all of these methods, have a decrease in AMH when you look at it immediately post-op. So when you plot AMH with respect to time after surgery, like 3 months after surgery, it goes in the ditch. But in the majority of the studies, especially of only one ovary having a cystectomy. By 1 year after surgery, the AMH is back to very close to where it was beforehand. Ablation, which is the plasma jet, also decreases AMH, but not quite as much as doing a cystectomy. But the upshot is pregnancy rates are basically similar, and ovarian cystectomy has the highest likelihood of the patient having a spontaneous pregnancy. And so it's like, so what are we doing looking at AMH and stressing out about AMH if all of these studies put together really show that pregnancy rates you can do whatever. Sclerotherapy is not good because there's a very high recurrence rate and very low spontaneous conception rate. So I don't recommend sclerotherapy. Oh, I jumped ahead. So basically the pregnancy rates after surgery, depending on which study you looked at, it was in the 40 to 80 range. So pretty darn good. So this is a video that my lovely fellow Dr. Yagi made, and she's by a pool in Orlando somewhere, schmoozing it up with Vidali and Sally Sorrell. But I'll let her, she's gonna talk.
In this video, you will see a left ovarian endometrioma and its removal by an ovarian cystectomy. An endometrioma is a cyst of deeply infiltrating endometriosis within the ovary. You may have heard of these as chocolate cysts, and a bit later in this video you'll see why. Often there can be adhesions of the endometrioma to surrounding structures such as the uterus, the pelvic sidewall, and even bowel. In this case, there are mild adhesions of the ovary to the sidewall, uterus, and the bowel that are separated before the endometrioma is excised. Here, the ovary is separated from the sidewall, taking care to avoid the ureter lying below. The reason it is important for someone experienced with endometriomas to operate on them is so the endometrioma is fully removed and the normal ovarian tissue preserved. Rupture of the endometrioma shows chocolate fluid emerging from the cyst.
As we used to say in med school, there goes another food group.
Here, the cyst of the endometrioma is carefully and fully removed from the ovary. And here you see the ovary being sewn closed after the endometrioma has been removed to prevent the raw surfaces of the ovary from adhering to the pelvic sidewall below.
So if you don't close the ovary that big, I call it an ovarian pancake, it will stick to things that are underneath there. And most gynecologists don't close the ovary. And this is what happens when the ovary isn't closed. So this is a patient of mine who, 6 or 8 months earlier had a cystectomy, had an endometrioma that was drained by a generalist somewhere in the Midwest. And this is the sigmoid colon, and it's just plastered over the top. And I wanted to make a video, but I didn't have time. Plus, it would be too hard. And so this is what the sidewall, this is what the adnexa looked like after we got the sigmoid off. And if you think this all looks like chopped liver, I don't blame you because it kind of does. This is the fimbria. We finally found them. It took me forever to figure out what's tube and what's ovary. And in here, there was chocolate fluid that came out. Here's a little bit of what looks like an ovarian tissue underneath here. But this gal lost her fallopian tube because of bad surgery. But it's totally acceptable for general gynecologists to do this to people. And I don't understand why. So if I have one mission in life, it's to get everybody with an endometrioma to an endo specialist to operate on it, because they're either going to have too much of their ovary removed and have like hardly anything left, or they're going to have a persistent endometrioma, or they're going to lose their fallopian tube. Probably 15-20% of these gals have damage, permanent damage to the fallopian tube that makes us have to take it out. So We started late, and we're running out of time. So, endo in the intestines happens at least 12%. In my practice, in Redline's practice, it's closer to 30%. So in referral practices, it's much higher. We see it associated with endometriomas and then deep disease in the uterosacral ligaments and the rectovaginal septum. Symptoms are severe pain with defecation, nausea, bloating, and worse pain with firmer stools. The options for treatment are a discoid resection, which is either partial thickness or full thickness, and we can do this for lesions less than 2 centimeters in general. And then for the larger lesions, we need to do a segmental resection. A lot of times, endo on the bowel wall, because of the fibrotic nature of the disease, the nodule of endometriosis kind of pulls the colon into a big kink. And so these patients will feel the stool coming down, and their colon will kind of contract and contract and contract, and they'll have this crampy pain. And then they'll get pain from the stool hitting the nodule, and then they'll get the sharp pain from the stool hitting the nodule, and then eventually they'll feel, oh, whoo, and it goes around the corner, and they have some will pass out, they have severe pain, and then 10 minutes later they're better. And that's kind of the classic symptom of deeply infiltrating disease in the rectum. So this is an ultrasound of a patient of mine, and this is kind of normal thickness of bowel wall. It's somewhere between 2 and 3 millimeters. And then this is sagittal, and this is sagittal, and this is transverse. And this thing is 3.5 centimeters in total length, and then the thickest part of it is about 1 centimeter. And this required a low anterior resection. This is a specimen for not that same patient, but a different patient. And this is kind of the bulky part of the nodule, and then you can see this little thing sticking up that's actually the full thickness disease sticking up in there. Only 3% of intestinal endometriosis penetrates the mucosa, which is why the GI docs don't understand it, because they can't see it on colonoscopy the vast majority of the time. So these are a couple of studies that are cohort studies. This one's from Brazil. The Brazilians, there's a ton of women with endo down there in Brazil. And there's a group at the University of Sao Paulo who's really good at it. They did 34% discoid, 42% segmental resections, and then they had a few ileocecal resections and appies. And they had really good outcomes with 7% complication rate of fistulas, obstructions, etc. This is another study which was a retrospective review of 34 articles. 71 to 93% were pain-free at a year. There's a 14% recurrence rate and 23% clinical pain recurrence, which a lot of times the pain is from stenosis of the anastomosis. Sometimes GI can dilate that. Once in a while they need a re-resection, because if you made your resection margin too close to where the fibrosis is, the fibrosis in the endo will cause that to stricture down. So we've had a couple of patients who had bowel resections other places. They didn't see another nodule of endo that was down deeper in the pelvis. They did like a sigmoid resection, and there was a rectal nodule still there, and so we had to, and she kept getting stenosis of the anastomosis, so we had to re-resect the anastomosis as well as the rectal nodule. And fertility rates for this paper were 10 to 30%. Roman and his group did actually the only randomized trial looking at patients were randomized into low anterior resection versus discoid resection. And they had very similar outcomes, because he did discoid resections in women with like 4 to 6 centimeter nodules, which is crazy. And so they were really big, really low. And the upshot is really that both groups, over half of them had pretty much normal ability to hold their stool until they got to a nice toilet. You know, nobody wants to poop in a nasty, dirty gas station bathroom. And so that's kind of how I look at success is, you know, do they have relatively normal stools, the absence of, you know, pooping every time they pee, which really doesn't bother them because if they're not passing out every time they poop, most of them don't care if they poop 7 times a day. But it's really being able to defer defecation that is helpful, and that really has to do with how much rectum is preserved and where the anastomosis is in relationship to the anal verge. So we talk about anything lower than 10 is like an ultra low anastomosis, and that will take away some of the storage function of the rectum. So, do you want to hear about IC and levator spasm and IBS, or do you want to watch videos? IC, okay. So, IC has changed throughout the years. When I first started seeing IC patients, you had to do a cysto with hyperdistension, and you had to prove all. There was like 15 things that you had to kind of check off that they had or didn't have. In 2006, I think it was, this paper came out, and they changed the definition, and they also changed the name to PBS. So you can watch Kermit the Frog and Oscar the Grouch in your bladder. And so basically, IC is somebody who has pain associated with full bladder, urgency and frequency in the absence of an infection or other anatomic thing to cause it. So the reason that women get interstitial cystitis, and men get it too, but much less frequently than females, Lowell Parsons proposed this concept that the reason that IC happens is because of a defect in the gag layer. So the gag layer is glycosaminoglycan. It's basically a big long chain sugar that acts as this kind of mucus barrier for the bladder. It's kind of like a garbage can liner for the garbage can of the bladder. And so the gag layer prevents the solutes in the urine, like potassium and acids and other things, from interacting with the urothelial cell layer and the neurons that are in those cells. And so it's also associated with mast cells and histamines and all these little inflammatory media. Well, the reason for that is because what causes this defect in the gag layer is this concept of visceral and viscerosomatic sensitization. How many of you guys understand this concept? So I don't have to keep going at it. Okay, about half of you. So essentially, these slides are from Karen Berkeley at Florida State, who's done a lot of research into pain processing. And she was the one that kind of coined this term pelvic organ crosstalk. And essentially what it is that anything in the pelvis that is sending a pain signal, those fibers, those nociceptive fibers, go into the dorsal horn of the spinal cord. The spinal cord is supposed to be protective of the brain. It's kind of like the bouncer to keep the riffraff out. And so these signals, they hit, if there's too many of them, they hit this backstop, and they have to go backwards. Well, they're in the dorsal horn, all they have is sensory neurons. So they go backwards on these sensory neurons, and they either go into the bladder, the pelvic floor, or the perineum to cause IC, levator spasm, or vulvodynia. And it's when the signal goes backwards, I call the bladder the heat sink of the pelvis, because it kind of takes all this excess nerve traffic. Well, those signals go to a sensory neuron. The sensory neuron is like, wait, I'm supposed to send a signal, I'm not supposed to receive one. What do I do? And it kind of throws its hands up and releases all these little inflammatory mediators. And it's those inflammatory mediators like substance P, nerve growth factor, cytokines, interleukins, all those nasty little things that cause the degradation of the gag layer that then allows the solutes in the urine to piss off the bladder wall. And so that's how IC happens. They used to say to do a diagnosis of a potassium sensitivity test. I haven't done this in 20 years. Essentially, I make the diagnosis with you have urgency and frequency and pain and you don't have an infection, okay, you've got IC. You don't need to do a cysto unless they have persistent hematuria. I've pretty much stopped doing cystohydros because half the people, they make them worse, they give them retention for a week or two. If somebody comes to me and says, I had a cystohydro 2 years ago and it helped me for 6 months, will you do one? I'll say sure. I don't mind doing them, but I just don't think that they're for everybody. All right, so how do we fix IC? Well, I fix it by getting rid of their endo, because 80% of women with IC have endo. Maybe it's not quite that high. It's on a slide somewhere in here. So the diet is really helpful, but again, it's not the be-all, end-all. ICHelp.org is the website of the Interstitial Cystitis Association, and it has a lot of information on diet. Their information on causation is not really accurate. But some people have relief from antihistamines and tricyclics. Some people, they have too many side effects from the drugs and it's not really worth it. We do bladder installations. Basically it's like half 2% lidocaine, half percent marking, and then a little bit of bicarb. We'll throw Elmeron in there if they can get it. Elmeron is a drug that is designed to rebuild the gag layer. It's meant to be taken orally, but it takes 6 to 9 months to work, and it's super expensive. It works better putting it directly into the bladder. We used to use heparin, and now we went through a period of time when nobody could get heparin, so we kind of quit doing that. You still can. And then PT is always helpful for IC because it's part of what causes the urgency and frequency is that their pelvic floor is in spasm and they can't empty all the way. Levator pain. 80% of women with endo have levator spasm. And again, the viscerospastic convergence guarding reflex. A lot of times people will they'll say they have pain with bowel movements, and it's at the puborectalis, and this is the fancy Latin name, so you guys can, chalk one up on your list. You learned a little Latin today. But PT works most of the time. When PT doesn't work, we can do Botox. We also have compounded suppositories made for our patients that have combination of tetracaine, which is a long-acting local anesthetic, amitriptyline, which is or gabapentin. Usually we use gabapentin, baclofen, diclofenac, and sometimes we put a little cyclopentone in there too. And the suppositories work really well for after PT, after sex, or some people use them every night, but after a while they don't need to use them every night, but after you guys get in there and dig around a little bit, it's helpful to kind of calm things down. Puborectalis, this is my view, this is your view, you probably know this. So I'm right out of time, so we won't take that. So basically, myofascial pain is multifactorial. The things that I see frequently is a lot of women will have hip pain, they'll have spasm of the psoas, the obturator, and piriformis. Usually that tells me that there's some sort of impingement, whether it's real or functional. A lot of times it's functional because the endo will cause an unequal spasm of the pelvic floor, which then causes a pelvic obliquity, which then causes a restriction in a hip. So usually what I recommend is that we get the endo out first because we know that has to happen, and then I send them to PT, and if they get better, great, and if they don't, then we'll send them to the hip surgeon to try to figure out what's going on with their hip. Pain at the attachment of the ribs and the abdominal wall. I see a lot of women with pain up here, especially on the left side. Nobody can figure it out. On the right side, they have gallbladder studies and appendix studies and all these imaging. What it really is it's the pelvic floor being spasmed and throwing a party and calling his buddies and saying, hey, I don't want to party alone, come join me. So then it gets the pelvic girdle, then it gets the abdominal wall, the QL, and it causes pain where the abdominal wall attaches to the ribs. The intercostals will sometimes be pissed off, and so sometimes it can go all the way around here. But the underlying root cause of all of that is the pelvic floor. IBS, 90% of women have IBS symptoms. Diarrhea, bloating, constipation, nausea. Typically they have constipation before their period from Levator Spasm, and then when they start the period, the uterus makes prostaglandins, which then gives them diarrhea, and then they get loose. One study, this study showed 37% of women with IBS have endo, and I think that any menstruating female that has IBS, that has pain with their periods, needs to be evaluated for endo. Because so much of the time, endo is what's underlying their gut symptoms. Inflammation is the mechanism because endo secretes all these little inflammatory mediators, which turns the peritoneal fluid into a toxic soup, and then the guts are floating around in this nastiness, and they just don't want to work. Who can blame them? And then don't forget endo. The terminal ileum and appendix can cause a lot of bloating and nausea. Cecum is a lot rarer, but even rectosigmoid endo can cause kind of more upper GI kind of symptoms. And this was kind of a fun study that I found looking at enteric glial cells. And the glial cells are kind of like astrocytes in the brain. They insulate the neurons. And so this group here took rats. These poor rats, they were given endometriosis, and then they looked at their glial cells, and it made the glial cells inflamed. It made them reactive. And then they found that these reactive enteric glial cells increased pain sensitization. So when they put their paws on a hot plate, they had more pain than they did before. And so this is really interesting when you think of how endo affects the colon and actually causes some of these IBS symptoms. Maybe it's not as simple as my toxic soup guts. So anyways, this is a video that I'm not going to show you. All right, I'll show you. But I can't fast forward it. I'm going to actually skip to this one, because this one is really cool. This one is a peritoneal pocket of endometriosis on top of the obturator nerve. And this gal had pain going down the inner thigh to right below her knee. And it's a short video. So we took the endo off of the uterus and every other place that it is. So these are the iliacs. The ureter is down here. You can see it peristalsing. And this is this peritoneal pocket on the sidewall. And so endo can cause peritoneal pockets, and what I like to do is I like to circumscribe the mouth of the pocket and then pull on the inside of it to get down to where it's actually at. So we're working, and eventually I get down here, and when I hit the cornering pedal, her leg jumps. And so you can see that jump right there. And so I have to switch to the scissors in order to get that off. And this thing right here, that is the obturator nerve, that white thing, white shiny thing. So here in a minute we'll switch instruments. So ureter is here, and then obturator nerve is like right there. And then this is kind of more nodular stuff here. You can see it looks a little thicker. And so some of these gals that you peel stuff off of their nerve, they'll be a little inflamed for a few weeks, maybe a couple of months, and then it calms down because nerves don't like their space invaded. I should have shortened this, sorry. So there's the nerve. Happy clean nerve. Alright. This is a long video that I'm not going to show you. So practical takeaways. What have I learned in almost 20 years of doing this? The most important thing is to treat all primary pain generators aggressively and promptly. So I think of endometriosis, adenomyosis, even an evil uterus that's not adenomyosis, ulcerative colitis, Crohn's, things like that are primary pain generators. Levator myalgia, IC, vulvodynia, those things are secondary pain generators. And the easiest way to think about it is like an onion. They're the outer layers on the onion. And you'll never fix it until you get to the thing that's causing it all. So, a lot of times, these secondary pain generators will improve spontaneously after you address the primary source. In our clinic, probably somewhere between a half to 2/3 of the gals with severe levator spasm, it gets better spontaneously after we do excision. And the rest you guys see. PT is much more successful after you remove the primary source of pain, because otherwise you guys can get it better for a while, but then it just kind of goes back up to where it was, and then so you're fighting an uphill battle. And so once you take away that stimulus for what is making the muscle spasm, then your interventions can be much more successful. For patients who have severe central sensitization, sometimes it's helpful to give them gabapentin or amitriptyline or Lyrica or something like that medically to kind of calm down their brain. But what's going to reverse their sensitization is removing all of their pain generators. And then we didn't really talk about this today, but educate the patients about pain processing, fear avoidance, anxiety, and depression, which is what you guys are so good at, and you probably already do this. I don't need to tell you. Patients with more severe psychological issues and a history of trauma, especially sexual assault or abuse or things like that, will benefit from cognitive behavioral therapy and stress reduction. And so, that's my favorite picture. Well, almost my favorite picture. These are thanks to my team. This is my fellow, Jen Yagi. This is my former fellow, Tristan Newmill. This is our nurse practitioner, Crystal. This is Terry Sullivan, our PT. And the big doofy looking person is me.